Hello, everyone, and welcome. My name is Dr. Julia Diallo, and I'm the Chief Medical Officer of GRC Advanced Recovery Network. So without further ado, let's get started. And thanks all for being here today. For sure, we're really excited to have you and to show you what we're doing. So Gateway Rehab has a really rich history, founded over 50 years ago by Dr. Abe Tversky. We've managed to save the lives of hundreds of thousands of patients. And I can brag about that because I had nothing to do with it, because it was before my time here at GRC. But today we are one of the largest nonprofit providers of substance use disorder treatment in the state. And with recognition that addiction is a chronic disease, much like other chronic diseases, with very similar relapse and recovery rates, we have implemented a chronic care model across our system, as this is a chronic disease. This disease tends not to respond to acute treatment episodes, and the fragmented care that is sort of typical of SUD treatment is really not very effective for people with SUD. So I'm proud to say that with the support of our board of directors and our leadership in the last 5 years, we have committed to providing evidence-based integrated SUD treatment across our continuum of care. Hence, our rebrand as GRC Advanced Recovery Network. Our telehealth program is an integral part of this model because it reduces gaps in care, it enhances engagement in treatment, and it provides access to patients who would otherwise struggle to access care or may not access care at all. To achieve this goal, we committed to building an enterprise level telehealth program. And really what that means is we have dedicated executive leadership. Our telehealth program is led by myself, the Chief Medical Officer, and our Executive Director of Telehealth, Matthew Rumba, who's sitting to on my side, ensuring that it remains high priority in our organization. We have a telehealth committee that drives our strategy, and telehealth is integrated in just about everything that we do. At this point in time, you really can't tease it out across our continuum of care because we're utilizing it just about everywhere. Change management is a big part of what's happening within our organization as well. So, requires cultural changes with our staff, with our patients, our stakeholders, our payers. It is the reason for this very event. We want to demonstrate to all of you the utility of virtual care, how we utilize it, when and how it works for people, and how incredibly effective it is and vital to a care continuum. We've standardized policies, workflows, and processes across our organization, utilizing one enterprise level platform, m.care, which we will soon demonstrate to you. And our platform is integrated with our electronic health record. Our program is expanding access to patients who would otherwise not receive care, improving outcomes, some of which we will share with you today, and reducing costs through integrating virtual care across our care continuum. We've made huge strides with regard to interoperability, with the goal being to create a seamless experience for both patients and providers. So a few that I want to mention here. We've implemented and operationalized OpiSafe, which connects us to the Pennsylvania Drug Monitoring Program, which, as you all know, is something that we have to check when we prescribe controlled substances. We used to have to go through many steps, many clicks. Now we can click a button within our EHR, and in 3 seconds, we can see the report, and it is brought into our electronic health record and stored there. We have deployed m.care kiosks. These are lockdown kiosks that we use across our residential and outpatient physical footprint, allowing us to provide medical and psychiatric services via telehealth at these locations without me having to hire a separate person for each site. So an example of that would be we have a psychiatrist or we have a psychiatric provider who is licensed at a busy in-person site like our 3.7 co-occurring unit, but we have a patient at our Green Tree outpatient location who needs psych services. We have a kiosk located at that outpatient site. We can put the patient in front of that kiosk and we can perform a telehealth appointment with that patient while they're an outpatient. So we do that a lot across our system. Behavior is a behavioral health tool that is integrated into our platform, which we will be demonstrating momentarily in the demo. But we use a 4-question survey, or Behavior uses a 4-question survey. It's a simple digital tool that allows our care team to know what each patient needs to hear to ensure the highest likelihood of engagement and behavioral change. So how to communicate with that patient in a way that resonates with their specific needs. So I'm sure we've all had this experience where you have a patient walk into the office and you interact with them in a specific way. Maybe you say to them, "We've seen you 3 times in the last 3 weeks, and all 3 times you have overdosed, and you were reversed with Narcan, and I'm worried about you. You know, this is something that could kill you," or, sort of a fear-based approach. Or I could have more of a spiritual approach in the way that I communicate with the patient. And I may see that resonate with someone, but the next person walks in the room and I say almost the exact same thing. I can see them physically disengaging and shutting down. And so this tool actually allows us to personalize our communication. And I'm looking forward to sharing with you some of the data that we have from the utilization of that tool. But that behavior tool is integrated within our M.Care platform. We also use a MedWand device, which we use primarily in our residential treatment facilities. But that is a device that looks like a computer mouse. It's the size of a computer mouse, and it looks like one. It provides a full set of vital signs. We can get a single lead EKG. I can auscultate the heart and lungs. I can look at the ears, nose, throat. I can measure a mole, look at a rash. It's incredible. Short of being able to palpate someone's abdomen, we can perform a full physical exam with this device. This device is also integrated into our system. So these are some examples of our progress that we've made with interoperability. So we are very, very excited still about having been awarded the first telehealth license in the state of Pennsylvania by the Department of Drug and Alcohol. And that happened last July. And after just several months, we had nearly doubled our patients. We are currently averaging about 750 telehealth encounters a week across our organization in the outpatient setting. We are averaging about 488 medical and psychiatric services as well. Those medical services will be for medications for opioid use disorder and medications for alcohol use disorder, so primarily buprenorphine, naltrexone. You'll see clinical virtual minutes that total over 230,000 broken down by both group and individual. So we're really utilizing our platform. We are very proud of our Nurses Health program that began last summer, and you'll be hearing from Katie from NHP in a little while. But since its inception, we have received 120 referrals and cared for 75 nurse professionals who have received treatment through this program. And we expanded to an additional 29 counties through that program. And we are now enrolling physicians and pharmacists through the PHP program. Here you'll see a demonstration of the state of Pennsylvania and the counties. The green stars represent where we have a physical footprint, where we have brick and mortar. And the other symbols you will see is an expansion of where we have a presence via telehealth. And it's really remarkable because the state of Pennsylvania, much like other states, is densely populated in the southwest and the southeast. But in the center of the state, it's referred to as a rural desert or a care desert, where there is a lack of care, lack of resources, and we are accessing people who do not have care or access to care otherwise, which is very exciting. In a bit, we're going to expand on some of these items, but I'll show you towards the end of the presentation that we have patient satisfaction scores on recent surveys, 10-question surveys, sample size of 344 patients that reflect an overall patient satisfaction in our telehealth program ranging from 89 to 95.5%. We're seeing access in patients who are telling us that they would otherwise not be able to obtain access to treatment. For example, a patient who will say, it takes me 3 hours to get to your Green Tree location, and I have to take 3 buses to get there. And this would not have been sustainable for me. Thank you so much for offering this care to me in this way. As everyone knows, there's a nationwide shortage of staff, and telehealth has really helped us from a staff utilization standpoint, similar to the example that I used earlier, where I can have a provider in one physical location providing care to multiple locations where patients are in need. And we can use, for instance, a psychiatric nurse practitioner or our psychiatrist on the highest acuity patients at other sites. Our patients report they feel comfortable in telehealth, that it's meaningful for them. We will forever be focusing on improving our user experience for both our patients and our providers. As we transition to other speakers and the demonstration, I'll introduce our telehealth team now. Again, I'm Julie Diallo. I am the Chief Medical Officer of GRC. I'm boarded in addiction medicine and emergency medicine. I continue to practice both. I oversee our medical staff at GRC. I'm very involved with quality, health, and safety. I'm proud to say that I oversee the telehealth program with Matt. That takes me to Matt. Matt is our Executive Director of Telehealth. He's, he doesn't like when I say this, but he's an impressive person. He came to us from the University of Mississippi, which is one of only 2 HRSA-funded centers of excellence in telehealth. Matt's been involved in passing vital legislation over many, many years in this country, in many states. He has built telehealth programs in the physical health space and now the behavioral health space. He's had extensive time at GE. We're really lucky to have you, Matt, and Matt is very much steering this ship. So if we say anything that you're impressed by, Matt and his team gets all the credit. Our clinical director is Stephanie Yorty. She oversees our clinical staff, and she'll be speaking in a moment about our ASAM levels of care and services that we provide. Our clinical manager is Ashley Plevelich. Our digital navigator is Adrienne Tracy. She does just that. She assists the patients with any technical issues that they have. Our telehealth admin coordinators are Dana and Kayla, and we have 11 telehealth clinicians who provide therapy. We have 3 licensed psychiatric nurse practitioners and a full medical staff that includes physicians, physician assistants, and nurse practitioners who provide MOUD and MAUD, so medications for opioid use disorder and medications for alcohol use disorder, through our Medication Assisted Recovery, or MAR, program. Abby Jolly will be speaking momentarily. She is our Regional Director of Outpatient Services. Chuck Ritter, our telehealth support from Information Technology, another key player on this team, helping today happen and helping every day happen in telehealth for us. Our presentation today will focus on our utilization of telehealth in our outpatient space. And at this point in time, we are going to stop sharing our slideshow, and we're going to have Stephanie Yorty tell us more about the ASAM levels of care and the services that we provide via telehealth.
Thanks, Dr. Diallo. Hi, everyone. My name is Stephanie Yorty, and as mentioned, I'm the Clinical Director of Telehealth. I have been in the telehealth world for over 5 years now, and really happy to be here with GRC. One of the things I really wanted to emphasize with explaining our clinical services is we as telehealth want to bridge the gap, a phrase that we've probably all heard before, but we want to do it in a gold standard setting type of way. So our goal is to help address fragmented care and allow space for like vulnerability, unique circumstances, and accessibility between treatment episodes. Recovery is not one size fits all, so neither is our GRC Hope from Home program. Some of the services that we offer are medications for opioid use disorder and alcohol use disorder through our MAR, Medication Assisted Recovery program, which we have physical locations, and we also have this conducted through our telehealth program as well. We offer psychiatric services, evaluation, and ongoing care with our licensed providers for our psychiatric services, the patients are involved with our substance use clinical services as well. We have the traditional stuff. We have intensive outpatient treatment, which meets either 3 or 4 times a week for 3 hours. We have outpatient groups that meet 1 time a week. And we also have this enhanced outpatient group. So it doesn't meet an IOP ASAM level of care, but we offer an outpatient group. It's an hour and a half, 2 days a week. And that is a really good place for people who maybe can't commit to an intensive outpatient program, but also really would benefit from a little extra support that maybe just 1 time a week would offer for them. Another thing, I'm going to expand a little bit more on some of our specialized programming because I feel like this also makes us, this helps with the unique factors of customizing our services for our patients that we're serving. We have our NHP program, which we'll have a spokesperson here soon to share about that. That one is very near and dear to me because it was one of the first programs that I was able to work on and revamp when I got here with Gateway. And it started out with 3 people and, at one point over 75 people. So we offer, multiple levels of care specifically for those nurses, which is really great. And the organic growth across the state is something to note as well, too. We also have our Adelphi program, and we have Chris here to speak on that as well. Something that's special for this particular program is being able to bridge that gap for those adolescents in a secure facility to have access to substance use disorder. We also have partnerships with AIU, and we have a working professionals group that is specific outpatient group for maybe those in the working field, corporate, paramedics, stuff like that. That's a little bit more focused on that work-life balance aspect. So that is our clinical services. And now I'm going to pop it over to Abby Jolly, where she can explain how you can come visit our program. Thanks.
Hi, everyone. My name is Abby Jolly. I'm the regional director of outpatient services here at GRC. And in order to enroll in a telehealth program, it's a pretty simple process. Your referral will first need to schedule an evaluation. Evaluations can be done either in person at one of our 9 outpatient sites or via telehealth with one of our 9 evaluators. All the patient needs to do is call our central scheduling department by calling GRC's main number and choosing option 3 for scheduling. The patient will speak to a scheduler for about 5 to 10 minutes who will gather some basic demographic information, their insurance information, and then they will schedule the evaluation. We offer outpatient evaluations Monday through Friday. Evaluations can be made same day if needed. The patient will then meet with the evaluator. The evaluation itself takes about an hour. Included in the evaluation is a biopsychosocial assessment and a telehealth assessment where we assess appropriateness for telehealth services. That assessment includes ensuring that the patient has suitable devices, connectivity, in addition to determining their clinical appropriateness. We have a patient portal where all consents and any required paperwork that require a signature can be completed. And at the conclusion of the eval, the evaluator will make a recommendation for treatment based on ASAM criteria. We also discuss psych services and medication management with patients at the initial evaluation. That is a conversation that happens throughout treatment, but we want to make sure we are starting that conversation at their initial evaluation. And then at the conclusion, we review all groups, and we have a lot of options, a lot of group options, a lot of times available. We review all of those with the patients to see which days and times will work best for their schedule.
All right, we're going to pause for any questions that anyone has at this point.
We do have a question in the chat, which is, with telehealth services, do they ever have to come in office?
Sure. I can answer that. So sometimes we'll have patients come in the office if they are receiving any in-person services. So one example would be if they are receiving a long-acting injectable medication like Sublocade or Vivitrol, they would come in the office for that injection, really only because they need to get the injection. We also test urine drug screens. So people will drop off urine drug screens typically at their convenience. And we can also have them get urine drug screens off-site at various laboratories. We actually have an interactive map on our app that the patient can use to find the most convenient testing center to where they live. But otherwise, no, they don't have to come in person. Any scenarios that I can think of. Are there any other scenarios that you can think of?
No.
Okay.
Another question in the chat. What factors do you consider when determining if they are clinically appropriate for telehealth only?
Just fine.
So,
I
yeah.
can speak to that if
Abby
you
was
want.
just talking about that. Yeah, yes, Abby.
Okay, yeah, so we want to make sure that they are at low risk to themselves and others. We want to make sure that they understand when they're logged into group that they need to have a place where it's going to be confidential, that they're not in the middle of their house with others that could see other group members or anything like that. So we want to make sure that all of those factors. And then in addition, we have had some folks that have done telehealth and they were just not as engaged. They've not succeeded at a telehealth program. And then we will want them to come in and try an in-person group.
Abby was mentioning the importance of that telehealth assessment. So not only is it appropriate for the patient, but we actually go through a questionnaire with them to ensure that they have the right tech in place and everything that Abby was talking about. And more importantly, it comes down to the fact that the patient feels comfortable with the devices that they have, and we provide them basically a telehealth user guide. So all the patients are receiving a user guide, top 10 things, top 20 things to think about. So her team really does a great job of assessing. Somebody may want telehealth, but it's just not conducive for them at that stage. So it isn't always, they might want it, but it might not work out for them. And others will be like, yeah, I really need it. And they can line up properly for it. So I commend her team for how they assess the patients.
Okay, we do have another question. Are you able to use the MedWand device work with telehealth participants? And if you are, how does this work?
Yes, so currently we're using the MedWand device internally. You could in theory use it though externally.
Yeah.
Because the person can do a self-exam, so you can guide them through an exam. But the way we use it currently is we have staff who are trained to use the MedWand. So for instance, a nurse will place the MedWand on the chest in a specific area to pick up the heart sounds, the lung sounds. They'll shine the light in the mouth. There's a tongue depressor attachment. It's a very impressive device. So it can be used. We use it in the residential setting essentially to be able to perform a physical exam on a patient virtually, a really relatively full physical exam. Like I said, one limitation is that you can't touch someone. So you can't palpate an abdomen, for instance, or feel something. But you can certainly see it well, and you can listen to all the things that you would typically listen to. You can look in someone's ear, you can see someone's throat, you can see a dental abscess, those kinds of things, those common complaints that we get. And so the reason why that makes so much sense for us to use that is because prior to having that, we would just, if we weren't on site physically, we would have to say, well, you have to take them to the emergency department, or the patient would say, I'm not sitting around waiting until tomorrow. This hurts so bad, or, I need someone to look at me. So now we can do a quick exam, and we can look at that exam, and we can address the needs of that patient in real time. It's a great question.
Yeah, it's awesome. That makes sense.